It's now my pleasure to introduce Dr. Aakash Shetty, Assistant Clinical Professor in the Department of Medicine at the University of Alberta. Dr. Shetty will be sharing his experiences on deep brain stimulation, the very treatment I've had myself, as well as other approaches such as the use of botulinum toxin and EMG guided therapy to improve targeted muscle delivery. Please join me in welcoming Dr. Shetty.
So my name is Dr. Shetty. I'm one of the movement disorder specialists working at University of Alberta. My predominant interest is botulinum toxin injection as well as DBS, advanced or device-aided therapies for Parkinson patients. I'm one of the DBS neurologists working at U of A. I'm just going to start sharing my slides. Just give me one sec if I can. Okay, so I think some of my talk might overlap with Dr. Martino's talk and just the basics of dystonia, how dystonia impacts the quality of life, and what are the treatment options. And then, we can in a very few slides, because I wanted to have more of a discussion. So I'll do my presentation and then we can have a discussion about what the questions are and what treatment options, and if you want to know more about any of these treatment options. So this is the overview of today's talk. So talking about what dystonia is by definition, it is involuntary, sustained, intermittent muscle contraction. So this is what we call hyperkinetic movement disorder, leading to involuntary, sustained, and intermittent muscle contraction, leading to abnormal movements and posture. In short, what is happening is there's abnormal signals that are coming from the brain, and these abnormal signals that are coming from the brain, they're causing these abnormal movements of muscles. So there are muscles that shouldn't be contracting, and these muscles are contracting, leading to these abnormal posturing of body parts, and depending on which part of the body is involved. And this was historically described in 1911 by Dr. Oppenheim, who had initially described this as muscular deformance. And this is the background history. Initially, there was a lot of controversy about dystonia, and then later on, we understand this is more of an organic condition, where initially it was thought to be more of a psychiatric disorder and was misdiagnosed for many, many years in the initial stages. In brief, if I have to explain, what happens is, if you imagine the muscles being like a light and your brain being a switch, and then if the light is flickering just on and off, that is because there's abnormal signals coming from the switch. So that is what happens in dystonia, where there is abnormal signals being sent to the brain, from the brain to these muscles, which are causing these muscles to contract involuntarily. When we talk about dystonia, there are two ways to classify dystonia, depending upon what body part is involved and depending upon what is the reason for the dystonia. So depending upon what body part is involved, so in cases of, for example, if the eyes are involved, what we call blepharospasm, where you have normal spasms of the eye muscles. If you have neck involvement, then you can have cervical dystonia. If you have involvement of the hand, then you can have limb dystonia. So those are what we call focal dystonias. Sometimes you can have segmental dystonias when we have two body parts involved, which are nearby. For example, a lot of the patients who have blepharospasm also have oral or mandibular dystonias, what we call Mage syndrome. Sometimes they can have blepharospasms and cervical dystonia. So those are what we call segmental dystonias, where two body parts are involved. Or sometimes when we have something called generalized dystonia, where we have more than two body parts involved, and that's more of a system. Sometimes this could be genetic, sometimes it could be secondary, and we'll talk about what that means. Very rarely it can be hemidystonia. Usually hemidystonia means one part of the body, one side of the body, and usually those are structural lesions in the brain that are causing the hemidystonia. If you have to classify dystonia by the cause, a lot of them we know could be genetic. A lot of the focal dystonias, unfortunately, we don't know the reason for the dystonias, or in some of those patients, even though family history may be positive. Those are what we still think of idiopathic. Sometimes you can have dystonia following a brain injury, like a stroke. Sometimes it is tardive, following certain medication, or sometimes it's brain injury when during birth they can have hypoxic brain injury, and then they can have dystonia following that as well. Very rarely you can have dystonia with some neurodegenerative disorders like Parkinson's disease, and they can have what we call combined dystonia, where dystonia is part of one of the other movement disorders, and that is what we call combined dystonia. So this is a classification of dystonia, and that sometimes helps with in knowing what part of the body is involved, what is the probable etiology. It also helps us direct in what could be the best treatment options. I think Dr. Martinez spoke about a lot about the quality of life, how dystonia affects the quality of life. It does. It is not just, as he was mentioning, and I totally agree with him, that it's not just abnormal movements. There is a lot of these, there's so many studies, and we know from our own patients that how it affects the quality of life. There is a physical impact where the majority of our dystonia patients have a lot of pain. And in fact, most of the scales that we use for dystonia, there's a scale that we also look into, one of the scales that we call is twisters. That is the Toronto Western Rating Scale. And this pain is one of the important aspects of that scale to understand how much is pain impacting the quality of life, and it also impacts the treatment options and helps us deciding how to move forward. So yes, there's a physical impact. There is patients can have pain and muscle cramps. They can have difficulty with some of the patients who have dystonic tremors of the hand, or something what we call task-specific dystonias. It can affect some of their daily activities like eating, drinking, writing. Sometimes if it's very painful, or if they have limb dystonias, it can also affect walking. Because of the constant motor activity and the muscle overactivity, you can have a lot of fatigue because this is an ongoing process all the time. There can also be a big emotional and social impact because of the dystonia. Patients can feel embarrassed, self-conscious about these postures. The tremors can be embarrassing when they go in public because it affects the way they eat sometimes. A lot of the patients have anxiety and depression, and it's very well known that patients who have dystonia, there's a higher incidence of them having mood disorders as compared to just the general population. And social isolation is common. Patients are sometimes embarrassed to go out and do public activities because of the movements and the attention that brings along with these movements. And not everyone understands what is going on. It can also affect work, right? We know that a lot of our patients, when the dystonia is not well controlled, it can be difficult to work with the pain, with the movements. So it can affect the occupation. In very severe cases, it can also make patients lose their job, lose their independence, and then they're more reliant on caregivers for their daily needs. And then when we talk about these overall quality of life, these are these indexes that they use for quality of life. Patients with dystonia have a significantly lower quality. The scores are significantly lower as compared to normal population, both in regards to physical health, emotional well-being, and social function. And when you look at the burden of in regards to the quality of life, it's very similar to, as Dr. Martin was saying, it's very similar to someone who has a chronic neurological condition like Parkinson's disease. So it has a huge, huge impact on quality of life. So talking about what treatment options, as I said, some of these judgments are based on what kind of dystonia it is, and then what could be the possible etiology. Majority of the patients that we see with focal dystonia, as Dr. Martino was mentioning, they're idiopathic. We do not know the cause. Even though in some of those patients there may be family history positive, we try to do genetics, but a lot of the patients we actually don't know what could be the potential etiology for these dystonias. For patients who have focal dystonia, the best treatment option is botulinum toxin injection. How does Botox work is when I first started my talk, I said that these are muscles that are abnormally contracting. So when these muscles are overactive, you inject some botulinum toxin muscles in those injections, you weaken them, so it maintains the balance between the normal and the abnormal muscles, and that way it helps. Usually the effect starts within 5 to 7 days, and then it can last anywhere between 3 to 4 months. But it again varies, as Dr. Martin was saying, it varies from person to person. I follow close to 250 patients, and no two patients are the same for me. There are some patients, for some reason, it lasts for like 4 months. There's some patients that last for 10 weeks. There's a whole spectrum in between. So sometimes some injections work very well, some injections don't work as well. So the way, as I said, the botulinum toxin injection works is by weakening the muscles. At the same time, if it is too weak, that's how you get side effects. So one of the potential side effects for someone who's getting cervical dystonia could be if the muscles are too weak. If you are injecting somewhere in the posterior neck muscles, you can have the weakness of those muscles, and you can have a head drop. One of the other common side effects of cervical dystonia muscle injections is swallowing issues, which can happen with these injections. As Dr. Martino was mentioning, that every injector is very different. I had the opportunity to work as a fellow in 3 different sites. I was lucky to work at Toronto, Alberta, and back in India. So I've seen different injectors having different techniques and having different preferences for toxin. Fortunate enough to observe many people and learn from them, and everyone is different and everyone does a good job, I feel. I think the basics of injections are the same. Some people have different ways of injecting. There's no right or wrong way. And I always tell this to every patient that comes to our clinic that there's no right way. There's some basics of injections, but then I don't think there's any right or wrong way of doing injections. Because when I did join my practice, I did inherit a lot of the patients from someone who was retiring. So I had these discussions quite frequently because they would be like, "Oh, you inject very differently from the one that the physician who had retired, and he was one of my mentors." But then it's, as I said, it's individual preference, and I think it's a way that you're more comfortable injecting the way you've been trained and the way you feel comfortable. I don't think there's a right or wrong way of doing injections. And in the same way about toxins, each physician has certain preference in the way or the site that they were trained. So some people use Botox, some people use Xeomin, some people use Dysport. My majority of my practice has been with Botox and Xeomin, but I've been using more and more Dysport recently. And that's again because where I was trained, they were using more Botox and Xeomin. I haven't seen anyone use MyoBlock. I don't even know if it's available. If it's available, maybe Dr. Martino knows if it's available, but I haven't seen anyone that, at least where I was trained, use this toxin. So these are different types of toxin. They work pretty similar. Some of them claim to be better than the other, but I feel they're almost the same. So talking about botulinum toxin, how does it help? As I said, it reduces the overactivity of those muscles. So by reducing the overactivity, it reduces the muscle spasms, reduces the pain, reduces the abnormal postures, and hopefully retains the normal posturing. In some of those patients who have issues with upper limb and specificity, like some of those patients who have writer's cramp or musician's dystonia, or patients who have tremors sometimes in the upper limb, it might help and improve their ability to eat and write. And then some patients who have lower limb dystonia might help with the ability to walk as well. And hence, when you're improving their motor symptoms, reducing their pain, hopefully reducing some of these symptoms might also improve the quality of life. As I said, most of the patients need repeat injections. There's very rare occasions where after a few injections, symptoms have resolved, and that's extremely rare. Majority of the patients do require every 3 to 4 months of injections. And as Dr. Martino was mentioning, that there are we all have been trained differently in different sites, and there are individual preferences of some physicians. Some of them use EMG, some of them don't use EMG. I know some of the movement disorder specialists did not use EMG, and they still had good, to be honest, they had good benefit. A lot of their patients did well because the anatomy doesn't change. The anatomy for most patients stays the same. But EMG helps in a way that if you have the EMG, it helps in a certain way that you know what is the activity of those muscles there. If they're truly active, are we missing on some of the other active muscles that are maybe active? And then you can target those muscles. It improves the precision by if you know the anatomy, if you know the target muscles, and if you know exactly, we can locate it through some of the deeper muscles. The superficial muscles, most of the superficial muscles, you can easily target. You don't need EMG for that. So usually for more of the deeper muscles, it helps with precision. Sometimes there are overlapping muscles, it helps with that as well. And then indirectly, it might improve the treatment response. Like if you are injecting in the same site where you want the muscles, what the muscles that you're targeting, so it might improve the treatment response. It will improve the safety because then you're not using excess botulinum toxin injections. And that might reduce the side effects. And then most of the EMG, as I said, is for deeper muscles in the neck, deeper muscles in the lower limb specifically, like one of the few muscles like tibialis posterior might help. And then laryngeal dystonia, which I don't do it. I usually, the only person in Edmonton that I know is an ENT specialist that does for laryngeal dystonia. I don't do laryngeal dystonias. None of us in the clinic do laryngeal dystonia, but it does help with cervical dystonia. The deeper muscles of cervical dystonia, deeper muscles of limb dystonia does help in targeting, and specifically if you're doing task-specific dystonias of the hand, like musician's dystonia, or if you're doing writer's cramp, where you want to be very, very precise at the target because you don't want the other fingers to get weak. So it does help in injecting those kind of muscles. So there is a role of EMG, but then, as I said, there are many movement disorder specialists who do not use EMG, and they still get good. A lot of the patients have really good response in regards to the therapeutic efficacy. There's also ultrasound that can be used other than EMG. I wasn't trained. I'm not sure if Dr. Martino uses ultrasound, but I wasn't trained, unfortunately, at any of the sites with ultrasound. I would love to learn it someday and improve my clinical skill because it also helps in, again, visualizing the muscles directly. So again, for the deeper muscles, which are sometimes hard to localize, so just sometimes also with EMG, they might be useful, especially neck muscles. Especially somebody was asking about scalene. So scalene muscles, sometimes if you inject, there's a lot of vessels and nerves around, and those muscles can be, again, with ultrasound, maybe easier to inject. Again, you can also combine ultrasound and EMG together, and again, it will improve the efficacy and overall clinical outcome. And there are many studies to substantiate the same. Unfortunately, I'm not trained in ultrasound, so I don't have a great perspective or my experience that I can talk about ultrasound. But there are a few physicians in Canada who have been trained in ultrasound, and they use ultrasound for botulinum toxins pretty regularly. Moving to deep brain, so botulinum toxin would be the first line therapy for focal dystonia. But someone who has generalized dystonia, we cannot inject every site. For someone who has generalized dystonia, who does not have a secondary brain damage like a stroke or somebody who has a cerebral palsy or a hypoxic brain damage, those patients who have primarily a genetic disorder causing a generalized dystonia, which cannot be treated or has not responded to medical line of treatment, those patients would be good candidates for deep brain stimulation. Now, DBS has been there for almost 2.5 decades. It has been proven to improve the motor symptoms. It also improves pain and quality of life. So a lot of discussion happens around DBS. When we see the patient first is to understand whether the patient has generalized or focal dystonias. I will come back to focal dystonias and the role of DBS in those patients. But right now, I'm talking more about generalized patients who have generalized dystonia. So the ones who have more than 2 or 3 body parts that are involved. That is significantly impairing their quality of life and have not responded to medical line of treatment, the usual drugs that we give for dystonia. Those patients, if they don't, we usually do imaging, we do a very detailed assessment, and then it is seen by multiple teams, including the neurosurgeon, physiotherapist, occupational therapist, then would be seen by someone who does a detailed memory assessment, and then also a psychiatrist to make sure that the patient is safe and does not have any ongoing depression which needs to be treated. So if everyone is on board thinking that the patient is safe for DBS, this is something that has been done for 2.5 decades, and patients have really, really great response, especially for certain types of genetic dystonias and generalized dystonias. And talking about those patients, they have 60 to 70% improvement in their motor symptoms and pain. And then patients who have secondary dystonia, say sometimes who have stroke or sometimes who have hypoxic brain damage, or there is structural damage to the brain, these are the ones who do not have a robust response as compared to someone who has primary dystonia. But even in those patients, we consider them if even 25% improvement in their symptoms translates to quality improvement in quality of life, then we do offer those patients as well if they are quite disabled. Now, how does DBS work? I'll just put this short video. So you see that it goes, there are leads that go. This is more for Parkinson patients, but the targets can be very similar for Parkinson's and dystonia. So there's leads that go into the brain. There is a battery or a pacemaker that is like a battery that is there in the chest, and there is current that goes into the current that goes from this battery through the wires into the brain, into these leads. And so it's basically like similar to a pacemaker of a brain. That's how I describe it. Very, very similar, that it basically rebalances these brain circuits that are causing abnormal movements. The exact way how it works is still not known. And that's the uncertain part, but it works. And as I said, it's been there for 25 years, and it does improve a lot of the symptoms. The targets, as I said, is very similar to the targets that we use. The part that we stimulate is the same target that we use for Parkinson, but not that the disease, these two conditions are very different, but the targets are very similar, and they do help dystonia patients as well. So as I said, when we talk about generalized dystonia, there are few kinds of genetic dystonia, especially this condition called DYT1. That's one of the genetic dystonias. And there is like you have few patients who have improved so much, and it's very satisfying to see patients do extremely well to a point where they were disabled, not able to walk, and then every time you see them, there's a new milestone that they regain, that they're able to walk, then able to run. There's one patient who was wheelchair bound, was not able to walk, when I saw him the first time, was able to walk. And now he's reached a point that he goes for hiking, he's now skating, skiing, back to his normal life. So he was one of the DYT ones that we had seen. So it's very, very satisfying to see when patients, they do so well. So when you look at, this is one of the other motor rating scales, there can be an improvement up to 90%, 50 to 90% in general. and that there's also significant improvement in quality of life. And when you followed these patients, the benefits are sustained for even at the end of 10 years. Now, coming back to focal dystonia, one of the focal dystonias that we were talking about is cervical dystonia. So we have few patients of cervical dystonia that we have done DBS. They do improve, but those are the patients the ones that we consider for DBS are the ones who have failed botulinum toxin therapy. That means we have tried multiple times, or at least 2 different injectors have tried. At least in our clinic, we try to, one, if I have failed, I'll give it to someone else to try. See if they can, or we discuss among our group and see if there's something that we can do for the patient rather than doing a brain surgery. And then we try doing injections for these patients. If they still don't respond and they're not doing well, and they're quite complex, then some of these patients we have taken up for DBS. There is an improvement of 50 to 60% in their motor improvement, and usually that corresponds to the improvement in pain. So there is an improvement in both motor symptoms, and these are from studies. These from our patients in the clinic. There are a couple. At least we have 3 or 4 patients who have done DBS for cervical dystonia. Some of them actually still require both. They need DBS, and some of them are still getting injections, but not the same dose. And it's for some of the residual symptoms that is not being controlled by DBS. So we do both DBS and injection, but it's not the same dose. They do well with the combination of both botulinum toxin and DBS stimulation. So it's what to expect when somebody is getting deep brain stimulation is it takes time. It's a little different when you're seeing patients for Parkinson's disease or when you're seeing patients for tremors, especially tremors. The ones that for tremors, they get an immediate benefit. That means the first programming that they come in the clinic, we switch on the DBS device. They get the first programming itself, they get almost great benefit. Parkinson patient, it takes a little time because we have to adjust the medication and then up titrate the stimulation. So it takes a few weeks to months, couple of months to get that balance between the medication and the stimulation. For dystonia, it's slightly tricky because unless the patient has dystonic tremor or tremor, it's difficult to know in the clinic whether anything that we make changes to the DBS or any settings that we give them, whether they are improving or not improving. Yeah, it takes time for even with DBS to notice an improvement. So sometimes it takes close to 4 to 6 months to notice a significant improvement with DBS, especially with dystonia patients. Their response, as I said, when they have primary dystonia, that means there's no brain damage. And some of the genetic disorders, they have really, really good response. When they have a brain damage and that is causing the dystonia, usually the response is not as robust. For cervical dystonia, if that first line of treatment would still be botulinum toxin therapy, we will not be putting leads, at least not in our center. And most of the other centers, I'm pretty sure it's the same criteria, that they will still be trying botulinum toxin therapy to see if they can get benefit for these patients. If they are not able to get benefit with botulinum toxin therapy, then the next line would be DBS in those patients. As this is a brain surgery, none of the brain surgery would be without any risk. There is a risk of infection. There is 5 to 7% risk of infection. The infection is usually around the site where the battery is, or what we call the IPG. Very rarely can that infection spread around the lead, and that's extremely, extremely rare. But usually it's around the site where the battery, or what we call the IPG, is. And that can be easily treated with antibiotics. There is 1 to 2% risk of bleeding. That, again, there is a surgical risk that is there, 1 to 2%. Very rarely, following the surgery, can have swallowing issues and speech issues from the stimulation or from the surgery itself. Again, as any of these DBS surgery, you have frequent follow-ups. Initial stages is quite frequent. Once things are stabilized and they're okay, things are better for the patient and you have optimized most of the things, then the follow-up is 6 to 9 months. And then you have to keep making adjustments with stimulation based on the treatment, based on the response of the patient. And majority of the patients who are good candidates, there is a definite improvement in quality of life, both from pain, the mobility, daily activities. And as I said, it's very rewarding to see a patient who was not doing quite well, whether it's toxin injections or whether it is DBS, to see them improve and see the improvement in the quality of life. So that is very, very satisfying to see as a physician. So in summary, it's a very effective treatment. Best outcome is in generalized dystonia. As I said, there is a sustained improvement. Benefit takes time in dystonia. And then you need a multidisciplinary team. We have both Calgary and Edmonton have a multidisciplinary team to manage the issues that can come up with DBS. Some of these patients, as I said, especially cervical dystonia, require both. Even if they are on DBS, we do induce smaller amounts of botulinum toxin therapy. And these treatments are not cures. They do control, any of these treatments that we're talking about is not a cure. They do reduce the symptoms, ease the pain, and help patients leave more freely. And then is to improve, goal is to always improve the quality of life. That is what we thrive for. And then, yeah, I'm happy to answer any questions.
Let's all thank Dr. Shetty for a wonderful presentation. Thank you, Dr. Shetty.
I'm sorry I could not be there. I wish I could come there. I'm just on call this week. I finished my call on Monday, so I would not be able to leave the city for that reason. So
this is just as good, and we really thank you for presenting to us today. We're going to open up the floor and do a question and answer period. Dr. Martino and Dr. Shetty can share the questions or take turns answering or whatever you see fit.
I know there were some questions that were asked. We're happy to answer that as well.
We have one here.
Are there any non-surgical brain stimulation options for dystonia? Like RTMS, TMS?
I can take that if you want.
Yeah.
Only at in an experimental fashion at the moment, in the sense that, of course, some of these non-invasive. So there's a large number of the growing number of non-invasive neuromodulation approaches. Some of them have been available to research and technologically have been present for 20 and more years, really. RTMS is an example of that. But there haven't been groundbreaking clinical studies that have confirmed efficacy. There are some studies that have shown, including some recent ones, that have shown good signal coming from both repetitive TMS, repetitive transcranial magnetic stimulation, and transcranial current stimulation, mostly direct current stimulation, and I do think that time is really ripe to step up and leverage on these smaller studies to do a larger clinical trial. But again, I think this is not being done in a multicentric fashion yet, mostly because of lack of funding, but also because we are still trying to understand if we can study not only the clinical response, but also some biological markers that express the mechanism of dystonia, and that we should also be able to see changed after these stimulation, because mostly all these trials with non-invasive brain stimulation, they require not only a clinical outcome, but also some mechanistic outcome, something like, for example, some imaging biomarkers or other forms of biomarkers. And that is something that we still are struggling to. So what are the best biological markers? But other than that, I think that we're getting closer, and just as much as we also have an interest in low intensity or transcranial ultrasound neuromodulation as well, which can target, unlike TMS or TDCS, it can target deep regions in the brain, the same targets that are targeted by deep brain stimulation, but non-invasively. And so I think that in the next 5 to 10 years, there will be, I expect and I hope there will be an important advance in the application of non-invasive neuromodulation. At the moment, it is not approved anywhere in the world as a routine treatment of dystonia. Any form of non-invasive neuromodulation are approved, but I think we're making advances in that direction. And yeah, that's about it from me.
We have another question.
I've been on Botox for 11 years, and I just wonder if there's any studies that show it's less effective as it goes on, or how long you can be on it. Like, I've had injections for 11 years, probably every 3 to 4 months, and they have worked and are still working to an extent. But I just wondered if there's any long-term effects or long-term studies that show that you could be on it for the rest of your life and it would still have an effect.
I think for most of the patients, as I said, there are studies to show that most of the patients continue to have the benefit. There, in the past, when and I don't think it's with the recent toxins, and Dr. Martin, you can correct me, with the older toxins. This is like much earlier in the late 90s and early 2000s. With those toxins, there were some concerns with antigenicity. So there were some antibodies that were produced against these toxins, and then they were neutralizing the effect of the toxins. So there was benefit that was weaning off for some of these toxins. But with most of the recent toxins, they're quite purified with very low risk of antigenicity where it doesn't work. From the safety perspective, unless there is atrophy of the muscle, which can happen with long-term injection use, if most of the patients continue to have the benefit and there may not be a long-term side effect. We have patients that have been coming, not to me, but as I said, I've inherited practice from another physician. Some of the injection patients, they've been getting injections for 25, 30 years now. So they still have the same benefit and they continue to have the same benefit. Dr. Martino can correct me if I'm wrong.
No, of course not. I agree. Of course, there are also situations like of later non-responsiveness to toxins. There's a possibility that they stop helping as much as they did, and I think this is one of the most challenging situations for us as neurologists who use botulinum toxin. How to interpret this, and there may be. So this can be coming from different situations. The first thing, the most obvious that we want to make sure we rule out is that this is not the result of an habituation to the effect of botulinum toxin to the point that the patient has lost the feeling of how much they have been helped by the toxin, because so much time has elapsed since when they were not receiving botulinum toxin, and they may have forgotten the big change, and because they never really go back to square one, perhaps between injections, this may give the impression that they're not making progress. So I'm not saying that this is what happens in most of the people who claim that they're not being helped any longer, but it's something that we have to. And so what I typically do, sometimes I ask them, are you open to wait another month or 6 weeks to see if indeed you're feeling just the same, or are you feeling actually worse because now the botulinum toxin has worn off completely, and you can realize that it was doing something. Of course, in many cases, the alternative, another reason could be that there may be some progression of dystonia over time. So dystonia can become more aggressive, more muscles, particularly in cervical dystonia, more muscles can be involved, or there may be a loss of some compensatory strategies that correct the dystonic posturing and the dystonic movements due to age or due to other reasons. And of course, there can be also sometimes atrophy of some muscles that instead have an important role, as Dr. Shetty was saying, an important role in counteracting the dystonic posturing. So all these things can be happening. A very small minority, I agree with Dr. Shetty, I think only a very small minority of these people have neutralizing antibodies, have developed immunological resistance to the toxin. And the reason why we know that is because in the vast majority of these secondary non-responsive situations, we try to inject the toxin, for example, in an eyebrow or in a small muscle of the muscle that extends the big toe, to see if we can still get an effect of toxin. Because if antibodies are neutralizing the toxin, they should be neutralizing it throughout the whole body, not just where we are injecting it. And we see that there is a response in most of these cases. So I can't remember the last time where I strongly felt that a person had developed antibodies. It's been a long time, and I think it's unlikely, very unlikely. And there's an explanation for that right now.
We have 2 new questions. I'll just go to Brett here first.
I actually have 2 questions, but they're quick, I think. So I was diagnosed 2 years ago. I have pterygium dystonia. I used to be on lithium and Abilify. So I'm just wondering, because he was talking about the DBS, it's more generalized. Would I be a candidate? Would that help? Or what kind of, would that not be a good idea?
So for DBS, for tardive dystonia, it depends on the severity. That's number one. Number two, are you still on those medications? So first, you have to get the offending medications off.
No, I'm not on any of those anymore. I've been off for about 2 years.
2 years now? Okay.
Yeah.
And then it also depends on how, I'm not, unfortunately, I cannot see you on this camera, but depends on how disabling the symptoms are. So there are the case series for tardive dystonia and DBS. They do have a response. They do respond to DBS, but then there are also other medications that can be tried for tardive dystonias and tardive dyskinesias. I had a few of them that had more neck involvement and oromandibular involvement, and that we were still, for those of the tardive dystonias, we were still injecting those patients. So the first line would still be medication and then a botulinum toxin therapy if it is more focal, because usually tardive does involve more neck and oromandibular region. So if that is the case, then targeting first, if it's possible, botulinum toxin therapy, or if that is not possible, then the second line would be medication. If all of that has failed, and from a psychiatric perspective, there's no concerns, because we are putting a lead going through the frontal lobe that can actually cause behavioral issues in patients who have some kind of psychiatric disorder. So then making sure that you're safe from the psychiatric perspective. If all that has been cleared, then yes, and the DBS could be an option if all of these have failed.
Yeah, I have dystonia in my neck and then in my shoulder as well. My shoulder raises.
So that, I think, may actually pretty much respond to very well to botulinum toxin therapy, and as I said, I have a few tardive dystonias that I inject, and they're doing quite well.
Yeah, I've been on Botox for a year now.
And how has the response?
It definitely helps for sure.
Yeah. So I think that's a lot of the patients that tardive that I do only injections. I've not done DBS for them.
And then my second question is about injecting the scalenes. My neurologist has injected like one, I think he did the posterior, but he's nervous to do the other ones. But my physiotherapist is telling me that feeling those muscles, if he was to inject those with Botox, it would be very helpful.
I mean, I can let Dr. Martino answer, but I leave it usually the discretion of the neurologist. I think a lot of them they have. I mean, it's not my common practice to inject scalene. I don't inject very commonly in my practice. I do inject once in a while, but not a very common practice for me to inject scalenes, to be honest.
I mean, there are some patients who may benefit from injections in the scalene muscles for both for cervical dystonia, which is a bit more extended and has also some a greater component of shoulder elevation. Typically, it is safer to it is recommendable to use ultrasound guidance to inject the scalene. So I think that the issue is availability of ultrasound guidance. And if you have a neurologist who can provide ultrasound guided injections of the scalene muscles, or a physiatrist. Sometimes physiatrists, typically they inject spasticity, they inject limbs, they very rarely inject neck, but they can also be specialists who may help in that perspective. Yeah, so I think with guidance, I think they are safe. Of course, one has to evaluate whether it is indeed useful to target the scaling, and case by case, obviously. But if that's the conclusion, and if the pattern is, then I would seek a movement disorders neurologist who does ultrasound guided injections, or physiatrist.
Do you know someone in Calgary at the Foothills Movement Disorder Clinic that does that?
I do. I also, like Dr. Shetty, I don't inject the scalene often, but I use ultrasound guide. I don't use EMG guidance, for example, but I use ultrasound guidance because I inject quite a bit of tremor, including hand tremor as well, and so I use that, and I sometimes use also the ultrasound guidance for some muscles of the neck. Yeah, there aren't many. I know, and it's still something that we have to work on extending the training, and this is something that the botulinum toxin companies are very keen to support with training and educational opportunities. Sometimes, but the issue is that, as everything, if it's just a workshop of 1 or 2 days, you can get a general introduction and the basics. But if you don't do it regularly, then you're not going to learn. And there's also a component of safe self-teaching. And this applies to me as well. I got some basics from physiatrists, but then I had to go on my own. And it's not everybody wants to do that, or not everybody has the opportunity to be trained, and so.
We have a few more questions.
Dr. Shetty and Dr. Martino, I just want to personally thank you for this opportunity. This is my first symposium, and I've just been gathering so much information. I find it very, very helpful. I'm sure the rest of us do too. My question is kind of 2 parts, and it kind of has to do with geography, I think. You mentioned the repetitive TMS and the transcranial ultrasound. I'm wondering, is that just, because I think I've seen it on the website before, but that's specific to U of T. And I'm wondering out west here what opportunities we have. I know, Dr. Martino, I've participated in one of your studies where there was an MMR and mood disorder.
MRI and maybe some physiology TMS, but not therapeutic. Yeah,
Yes,
not treatment.
yes. So I'm wondering about that part. And the second part, also kind of geography, is I've heard a lot about Daxify with people on a Facebook group, mostly from the US, that say it lasts longer. I'm wondering, I don't seem to get answers from anybody when I ask that question. And I'm wondering if you could comment on both of those and see, for many of us, what hope there is in the future, if it's related to geography and the focus down east, have more researchers, and two, what's happening with the Daxify and Health Canada. Thank you.
Well, I'll just briefly, since I covered the neuromodulation, non-invasive neuromodulation piece. At the moment, as I mentioned, there isn't a clinical application of non-invasive neuromodulation in dystonia beyond research. So that not only in Canada but anywhere else. So that is the whole field of non-invasive neuromodulation, regardless of which technique one is considering, TMS, ultrasound, it's still experimental, and it still requires more research. There's promising signal coming from some of the small studies that have been done so far, but a big study that confirms efficacy and safety hasn't been done yet. So that's one. So in that case, geography is entirely limited to research participation, not to having access to these technologies as treatments, because wherever you go in the world now, nobody's going to offer you that as a treatment. So that's one thing. About the Daxify, I'll let Dr. Shetty comment first if he wants.
I'm not certain. I only know that there were studies that have come out, that was last year, that showed that they last longer and they're safe in cervical dystonia. I don't know if the Health Canada there's an approval for that, not to my understanding. There's some studies with botulinum toxin A that I think was published like 2 years ago, with they claim that it lasts longer. I don't have, I've started using more now in my practice, Dysport, based on that study, but it's just a single study. I think Dr. Martino injects more Dysport than I think Toronto. I know Dr. Fasano does, and I know Dr. Martino, I've heard that injects a lot of Dysport as well. But I've recently started using it, to be very honest. It's a very limited expert. I have some of these patients who are non-responders for me with Botox and Xeomin. I've moved to Dysport. But talking about that other one, the long-acting botulinum toxin, that there's only studies that I've read about, but I have not read about anything that has come on Health Canada that I've read about that is there for approval.
Yeah, I can add also my thoughts. So as far as the toxins that are available now, as Dr. Shetty was saying, yeah, there's an interest in exploring more and more whether Dysport, which is the British toxin basically, lasts longer. I mean, this is actually coming from some open label, so non-controlled, not case control, not controlled with, uncontrolled, and actually unblinded to study that has been done at Western in London, Ontario, that suggested that there could be a longer duration of effect of Dysport compared to Botox and Xeomin. This needs to be verified, absolutely. There's a rationale for that, which could be related to a number of reasons, including the fact that when we inject Dysport, we inject a larger volume of fluid, which can facilitate dissemination and spread in the area, and that might translate into more prolonged benefit. But this is entirely to be demonstrated. And when it comes to toxins, you also always have to be considering the fact that we will never have a comparison study between the toxins. No, so unless there is someone in hospital who wants to do it and has access to all the toxins and has funding to do it, the companies will never do it because they're afraid of losing the contest. It's more simple as that. So there can be only two winners or one winner and a loser, but it's complete. The reason why they are not actually doing it is just that, I mean, we don't know whether this is, I don't know what's behind it, but we don't. This is taboo topic with the companies. There's no point even in bringing it up. I mean, they're not going to do it. So we're never going to know if one toxin is better than the other. Our gut feeling is that they pretty much work in the same way. And frankly, I have used, before coming to Canada, I've used Dysport in the UK and Italy way more than Botox and Xeomin. And since I'm in Canada, I've barely ever used Dysport right now, more for practical reasons and logistic reasons than anything else. But honestly, when I have switched from Dysport to another toxin, and applying an adequate conversion ratio, I didn't see dramatic differences. So if there was such a dramatic difference, okay, sometimes, you know, if you don't look deep enough, you don't see things. I appreciate that. But my gut feeling is that there wasn't a huge difference. And so all this, the rationale, if eventually a good study will come out showing that Dysport lasts longer, okay, we're all happy. But at the moment, there isn't. And as far as the Daxxify is concerned, Health Canada is not, it's not approved. It's approved by the FDA, and so it's available in the US. I can tell you that I'm not going to name any names, obviously, but some very authoritative, leaders in the field of dystonia in the US have expressed skepticism about this narrative that Daxxify lasts longer. So, again, all the papers that have come out on Daxxify have been co-authored by industry representatives. So with toxins are a huge business. So with toxins, one has to be adamant about the quality of the evidence there, and not just. Of course, there are anecdotal experiences exist for everything. If you find someone on a Facebook group who has, you can find in a Facebook group you can find any experience on this world, because someone will have experience. I don't mean to demean individual experience. I'm just saying that we have to go by evidence, not by anecdotes, right? And so some people know, receiving Daxxify, that the studies have shown that they last longer, and they may have just got a beautiful placebo effect from it, and they've noticed that they've had but placebo is not enough to.
Yeah, it's just hard to take if they had something really good in the U.S. and we didn't. That's where I was going with that.
You're completely right, and yeah.
12 years, just like if you could stretch that 3 years out, how beneficial that would be. Completely. But generally speaking, Canada comes later, but for the crucial things, they always get to Canada. I think there's one area, for example, talking about tardive dyskinesia. I mean, there are new medications that maybe don't help so much dystonia, but they help dyskinesia more, so we use tetrabenazine for tardive dyskinesia, but there are new drugs, which are not new anymore, but newer than tetrabenazine, that help tardive dyskinesia, that seem to have a better safety profile, a better tolerability, and they have been approved in the US for a long time, and the company hasn't actually applied for approval to Health Canada yet. That's a little shame. It's not a gigantic miss or loss, but it's something, and it's a shame. And you have to consider that
sometimes if they have a patent on the product, they have to apply to Health Canada. Nobody else can just go there with a generic, because they still have the copyright and the patent valid. And if they don't, then the country will not have access, will not have approval, and therefore reimbursement and coverage. And they don't apply because Canada is a smaller market sometimes.
So we're going to take one more question from Brenda Curry, and then we're going to pause for a break. So Brenda.
Hi. Hi. I have a question about oral medications. Over the many years I've had dystonia, I've had different prescriptions prescribed to me. Why aren't, now I blanketly call all medications I've ever been prescribed just as muscle relaxants, whether they've been for anxiety, whatever. I've just wanted them for muscle relaxants. So anyway, why aren't all, quote, muscle relaxants on the list to treat dystonia? I was told by someone close to me that they took a certain muscle relaxant and that it wasn't addictive. There was nothing harmful about it. And so when I asked my doctor about it, he said, okay, sure, you can try it. That's no problem. I'll prescribe it to you. But it's not on the list. And I tried it, and I don't take it often, only when I think it would benefit me and I'm really worked up. But it does work for me. But I had never been prescribed it or offered it before. I'm just wondering why it's not on the list. Why? Because a long time ago, I think my mom heard many, many years ago, different combinations of different drugs. If a person tries a little bit of this with a little bit of that, and they work together, they can really be very helpful, or even on their own. But why aren't they all on the list? Is that a valid question?
I let Dr. Martin answer because I know Brenda quite well, to be honest. So
No, I mean, I'm actually, I don't want to be intrusive, but at this point, I'm curious to know which specific medication you're. If you want to share, if you don't worry, if you don't want to.
It's cyclobenzaprine, I believe it's called. Cyclobenzaprine.
Cycloben, so that's that's cycloben. Yeah, okay. So there's even some anecdotal evidence even showing that cyclobenzaprine can even aggravate dystonia, for example. Just like other medication like Gravel, and D-menhydrinate, similar medications as well. Before botulinum before DBS, the big movement disorder specialists were talking about the 80s. They were using, for generalized dystonia, they were using so-called triple therapy. So they were combining anticholinergics, tetrabenazine, that I just mentioned, and an antipsychotic medication, a neuroleptic. Neither of these three classes are, strictly speaking, muscle relaxants. And now this is not used anymore because we have better treatment for generalized dystonia when we can. We don't use anymore that much of antidopaminergic or neuroleptics or antipsychotics because we know that they can aggravate dystonia. Tetrabenazine really doesn't help that much, but it was felt that the combination of these three medications could help. The effects, frankly, and even at those times, were not major or huge. And then DBS came on, and it became so much more powerful and helpful than these pharmacological attempts that this triple therapy is not used anymore. We use still anticholinergics sometimes, artane, benztropine, and other similar in that class. We use I don't have any issue with muscle relaxants that don't act on dopamine, simply because unless one has a dopa responsive dystonia, which is a particular group of genetic dystonias, typically medications that act on the dopaminergic transmission, they don't really help dystonia, even though there is an interest in exploring all this more. And so we use medications that act on another neurotransmitter called GABA. And so it's baclofen, it's gabapentin, and benzodiazepines definitely can help dystonia. They're highly addictive, but they can help dystonia. And so specifically cyclobenzaprine is because it can also aggravate dystonia. And that's probably why people, most of us, and I put myself in that, would be a little cautious in considering it. But all these are off-label. So all these are proven medications that we have available in Canada and that can be prescribed. So I don't know exactly which list your doctor was referring to. There isn't really an official list of. We don't even have guidelines to treat dystonia in Canada. We don't have national guidelines for dystonia. So
I'm paraphrasing and
okay.
Yeah. But that's kind of how I took it was, this had the potential to be helpful, but it wasn't being used to treat dystonia. And then I tried it, and it did relax me and hasn't aggravated me. And I know everyone's different too.
Yeah.
So, but I wondered, because this is helpful to me, why I hadn't heard of it. I heard it from someone else and not a doctor. So just kind of wondered.
There are some physicians who are open to try a lot of medications, and others who are just saying, listen, I've done everything that I think I should be doing, and that's it. And speaks more to the differences, the difference in attitudes that physicians can have.
Because my mom, I've been dealing this since I was very young, so my mom's been the one who, was always my advocate and the one asking questions because I was a bit too young. But she was always grateful if a doctor would say, let's try this. It's just something new. May not work, but let's try it, because you just never know. And was always glad to try something new because there's a potential there. So anyway, okay, thank you.
Let's give a big round of applause for Dr. Shetty and Dr. Martino.
Thank you, everyone.